Jeddah, as in Saudi Arabia. He has got, about more than 7 to 8 years of experience working as a consultant in UK. Right now, he is working in Saudi Arabia. So, with that kind of experience, and he has been in the FRCR, he takes a lot of interest, particularly vis-a-vis breast imaging. So, the tips which he will give you will be gold for you. I think we are very lucky for him to be with us today. So over to you, please.
Thank you, Dr. Khan, for the introduction. So, as Dr. Khan
Sorry,
mentioned,
sorry to cut you. Sorry, I forgot to mention for the audience, the format is going to be slightly different. First hour is going to be a sort of a lecture, and then there will be a hot seat viva, 5 candidates, and each candidate is going to get a single case. Sorry for that. Over to you.
thank you. That's okay. So, thank you, Dr. Khan, for giving me this opportunity. As Dr. Khan mentioned, I was a consultant in Stockton-on-Tees, started in 2017, and before that, I did my training in Newcastle and Middlesbrough, so Northern Deanery region, getting my CCT in 2016, then 1 year of fellowship in breast, and then as a consultant. So I stayed there till 2024 and then moved to Saudi Arabia and Jeddah. I'm still doing the breast and general radiology work here. Now, the breast radiology for FRCR. Now, not all the candidates do get these cases in the exam, but if you get it, I feel you will be lucky because you can score maximum points in the breast case. Um, these are more objective cases rather than more subjective, and quick to answer, especially for the written component. These are the ones where you can save time, you can score maximum points. So what do they want to know from you as a examiner? They are not looking for anything super specialized, or they're not looking for anything weird and wonderful. They are just looking for the basic imaging, and they just want to make sure that you are safe breast radiologist, so you're not missing things. So I will start from the basic, uh, the anatomy. So you can, from back, from starting from the posterior aspect, you can see there's a chest wall. Then you get your pectoralis muscles, then breast fat, and then these retroareolar ducts and glandular tissue. So this is a basic anatomy. They're not going to ask you anatomy, but this is good to have in your mind. And sometimes you may be able to see some lymph nodes in the axillary tail in this region, so just to be aware of it. Okay, so yes. So what is the basic imaging is the mammography, which we use. Now, there are two standard views, and for mammography, which I'll show, and how you go about it. So mammography in UK, there are certain guidelines you have to follow. There are two types of clinic when you do in UK. When you are seeing a breast patient, either they present as a symptomatic patient, which means they have felt a lump themselves, so they have some kind of symptoms, they have pain, they have discharge, they have distortion, so they will go to their GP and will be referred to one stop clinic or symptomatic clinic. The other one is screening. So initially, screening age was 50 to 70 in UK, and they have trialed it with extension 3 years on each end, so 47 to 73. So these are the patients who get referred, who go for screening, get their mammograms looked at by two radiologists, and then they decide if they need to come in for further assessment or not. And it forms a part of triple assessment, which I'll go through. So routine screening, one-stop patients, which are more than 35. Now, reason I have written 35 here, these are the patients in which we do mammograms. So the NHS guidelines were slightly different. Initially, they were doing mammograms in patients who were above 35. Now they have changed it to 40. It's just to save them from radiations. So, but it varies. Most of the places are still doing 40 now as a cutoff for the mammogram. You only do mammogram below 40 if your patient has a cancer, you have done ultrasound, found cancer, and it's proven, then obviously um, it falls under the IRMER guidelines. So you do it now. Two view mammography. Now, when you are doing or when you're going through a case of breast, and this is my own experience, it happened with me in the exam. The examiner put the mammogram up and she asked me which views are those, and I said these are the mediolateral oblique and craniocaudal views, and she just took the film down, and I was surprised. So sometimes they are just looking at the basics. Now, the mediolateral oblique is in front of you. This is the right side, this is the left side. Again, this is the craniocaudal, right and left. Now, in medial lateral oblique, you compress the breast from side to side. So from, as the name says, medial to lateral, and you draw a line like this. So this will be upper, this will be lower quadrant. So you can divide with the medial lateral film. You divide the breast into upper and lower quadrant, and you draw a line from nipple going back. Okay. Craniocaudal. In craniocaudal, again the name CC view, where you compress the breast from cranial to caudal region, so from top to bottom, again, and then you draw a line backward. So this will become your lateral, and this will become your medial. So by looking at now, you can divide breast into 4 regions. So if you draw a line here, if I draw a right breast here, so you draw it. So this will be your upper outer quadrant, lower outer quadrant, upper inner quadrant, lower inner quadrant. Okay, so you divide the breast in 4 quadrants. Some places use clock face, which I find it difficult, especially in exam scenario, because you can confuse right to left, left to right. Is it 2 o'clock, is it 3 o'clock, is it on the right? So it's best to stick to upper outer, upper inner, lower outer, lower inner. So you divide breast into 4 regions. So again, most cancers, for some reason, is more common in the upper outer quadrant. So just to be aware of. So when they ask you in the exam, you can start your case by saying standard 2-view mammography ML and CC views of both breasts. Never start answering the case until unless you have seen both views. So you need to see MLO and CC views, and only then start your case, because otherwise you can confuse things. So this is the basic anatomy for this. And as we go along, I will explain how to answer the breast cases quickly and with minimum words and maximum scoring points. They may ask for further, do you know any other views which for breast? Then you can obviously say there are rolled CC views, true lateral views, magnification views, and the Eklund's views they use for the patients with the breast implant. So if patient has a breast implant, then you can use these Eklund views. But these are, again, I haven't heard anyone mentioning that they have been asked these the further views. Most of the consultants will ask you the basic MLO and CC views. So again, as we did through the anatomy first, obviously you can't see the chest wall on this one, but you can see pectoralis. The dark bit is the retroareolar tissue with mostly fat this region, and then glandular tissue and nipple areolar complex and some lymph nodes in this region, normal appearing. Similarly, fat, retroareolar glandular tissue, nipple areolar complex. Now, again, if you want to score higher, you can always mention about breast density. So there are 4 levels. So again, if you start from level 4, you can see how dense this breast tissue is. More opacity is more white, more dense. Then obviously less opacities, and then this one, the level 1 fatty breast tissue with very minimal glandular tissues and scattered tissue. So these are the basic densities you see on this one. Again, BIRADS imaging, breast imaging reporting data system. Most of you must have read about it. There are some variations, obviously, between UK and American system. So in UK, just use 1, 2, 3, 4, 5, and again, it varies from department to department. UK as well. The general principles are same with some alterations, and obviously they discuss amongst their own team, the breast surgeons and radiologists and pathologists. So agreed. But generally speaking about it, uh, BIRADS 1 will be, negative for malignancy, 2 benign, 3 likely benign, 4 you divide into A, B, C, low suspicion of malignancy, moderate, high suspicion, and 5, very high suspicion of malignancy. In America, they use 6, which is biopsy proven malignancy, but in UK you may not. Some places just for the radiology they just use M1, M2, M3, M4, and M5. Again, negative for malignancy, benign, likely benign, probable malignant, and definitely malignant appearing. So these are the things you have to just bear in mind. Okay. Um, Dr. Han, just want to check. Can you see the drawings I'm making on the screen or not? Can you?
Yeah, we can see it.
Okay, that's good. So again, the classifications as I mentioned, 0, you use it for incomplete assessment. But again, that's more symptomatic. But these are the main 5 which you'll get in the exam, negative, benign, probably benign, suspicious, and highly suspicious. So these 5 you have to be. Now, obviously, when you will be given a mammogram, you will start by saying the standard 2-view mammography MLO and CC views of both breasts. I don't think they are giving you the tomosynthesis at this stage, but in case it is, you can always add on standard 2-view mammography MLO and CC views, including tomosynthesis. So this is how you start, and you don't need to say these things. I have been given a mammogram of a female patient. No, just mammogram, standard 2-view mammography MLO and CC views. Just save your time, save your words, and try to get maximum through your answer. Now, when you're given a mammogram, definitely it will have some kind of pathology on it. Either it will be microcalcifications, it will be distortion, it will be ill-defined density, mass. So how do you differentiate which kind of mass, or so these are different screening findings you will get on your mammogram. So you'll see either microcalcifications, well-defined lesion, ill-defined satellite stellate lesions, parenchymal deformity, breast asymmetry, which again you can get in syndromes like Poland syndrome or previous mastectomy or previous trauma or something. You can say symmetry, and then obviously suspicious history. It won't be in the exam, so you don't have to worry. So I'll just so when you're explaining again now, the first step is you have to say standard 2-view mammography ambulance CC views. The next step would be, I'll just yeah. So the next step would be you have to describe what kind of abnormality it is. So if you draw a right breast, suppose here. So suppose so what kind of, so you'll say standard 2-view mammography, ambulance CC views of both breasts, fairly fatty breast tissue or involuted breast tissue. There is ill-defined lesion or mass or ill-defined opacity in the right breast upper outer quadrant. Obviously, you won't be able to check the size, in the exam, you won't be able to measure it. But you say ill-defined opacity, there is. Now you have to give pertinent negatives as well. So we'd say there is no associated skin thickening or tethering. There is no nipple retroareolar complex retraction. So you have to mention those negative. You don't assess lymph nodes on the mammogram, but if there's a very large lymph node in the axilla, you have to mention that there is right axillary and large right axillary lymph node. So your answer would be, again, I'm repeating it again. So you just write those statements and memorize, so you don't spend time in the exam. So you will answer it: standard 2-view mammography ambulance CC views of both breast, No previous imaging for comparison. In the right breast upper outer quadrant, there is ill-defined lesion with no associated skin tethering or nipple areolar complex retraction, no associated microcalcifications or any other satellite lesions in the right breast. And then you stop. So what I said, you have to mention the quadrant. So you know which quadrant. This sheet is from the screening, from UK, the screening centers, how they used to write the thing. So you have to mention the quadrants size, which you may be able to. Now you may get two lesions, very rare in the exam, but if they give you, you have to explain the sites of both the lesion. Are they in same quadrant, are in different quadrant, and approximate distance between the two. So how do you describe the margins? Again, obviously it's very clear this one is very well defined, rounded, circumscribed, so this will be benign lesion, and so you will classify it as M2. M stands for mammography, or some places you are use R2 as well, radiological 2, but this is benign. Okay, this one is partially obscured, so you can see this is a well defined margin, but the this margin is not very well, so it maybe you can label it as M3. Microlobulated, again M4, and these indistinct and speculated ones, these are the ones you have to be worried about, and again in exam they probably will show you cancer because they want to get your approach, that how you approach these lesions. So benign ones, obviously they are straightforward, most of the people, but probably they'll more be interested in more the malignant lesions. So just to be aware of these. Again, density. Some lesions are low density, so probably you will see less conspicuous on the mammogram, equivocal density, and then high density. So, now this lesion, again this mammogram, if I'm splitting, obviously I know it's not a full picture, but you will say that there in the right breast retroareolar region there is ill-defined opacity. It's quite ill-defined margin, so ill-defined opacity with associated, so the skin is thickened, and bit retracted, so there is associated skin thickening with subtle nipple retraction. So again, and then when you are using these words, that it is ill-defined, indistinct, with skin thickening, then you have to make sure that you classify is it highly suspicious. You can't explain the features of malignancy and then say it's a B2 or M2 or R2 or benign lesion. So just to be aware of it. Okay. Again, microcalcifications, I can show you the pictures as well, but if they are more dense, thickened microcalcifications, if they're in history of trauma, you probably say fat necrosis and stuff, those are benign. Fine, linear, punctate, pleomorphic, these are more malignant, especially the segmental ones are malignant calcifications. So mostly benign calcifications will be, these are scattered on the skin, probably an artifact, from patients use different kind of cosmetic things which can give you calcifications. Milk calcifications, so more teacupping in the cyst. Rod like, you probably get more in dectectasia. So these are more straight lines, and there are no dots. They are not like this. So don't confuse them. Partially calcified fibroadenoma. Again, dense dystrophic, probably from previous surgery or trauma. Vascular calcifications. Again, more linear, as you imagine you see those in abdominal aorta or thoracic aorta or iliac arteries. So these are typically benign. These are the ones you have to be worried about. So they're not going to give you probably this kind of in the exam, because it's very subtle. You will probably get more these pleomorphic calcifications, cluster of microcalcifications, or fine linear dash dot calcifications, Again, finally branching or coarse heterogeneous. So if you look at the coarse heterogeneous here and this one, there's very, there's a lot of difference. This is more diffuse, thickened, and this was more coarse. It's not coalesced together. So just to be aware. And again, be aware when you are explaining the calcifications, if you are explaining suspicious features, then you have to label it as M5. So make sure that you use your buzzwords and then align them with the appropriate diagnosis. So in summary, the examiner, obviously as a surgeon, it says surgeon here, what the examiner wants to know is which side is the cancer, which quadrant, size if you can measure it, if axilla, you can see anything axilla, if there's any abnormality, distance from the nipple, and also commenting on the nipple areolar complex. Now, suppose you have answered, you have mentioned that there's a lesion in the right breast upper outer quadrant and it has ill-defined margin, skin thickening, nipple areolar complex retraction. The examiner obviously may ask that what would be the next step. Now, if the history is already given, if the history says this patient went to the GP and found a lump and GP has referred, then don't look at the examiner. Try to just explain the mammogram and just tell the examiner, based on these mammogram findings, my next step would be to do an ultrasound of this patient's right breast and axilla. Remember, the breast ultrasound is never complete without axillary ultrasound. You have to mention axillary ultrasound because they are not separate, they are one entity. That's it. So always remember, no breast assessment is complete with unless you have done the axillary assessment. So rather than examiner prompting you, you just say, given these findings, I will proceed with the ultrasound of the right breast and axilla, and then obviously I'll show you what how to do ultrasound. So it is used as adjunctive mammography for assessment of breast lesions, for guided procedures. So what's the use of ultrasound? So obviously you use ultrasound guided biopsies, drainages, primary screening tool, and ladies who are below 40, you use ultrasound as a main tool to avoid radiations for axillary assessment. Okay, so these are the all stuff you need to know about ultrasound. Now, don't worry about this, they're not going to ask in the exam. Some people say just as because so you don't forget. So that's a practical tip, that you start breast ultrasound from the axilla, just to keep in your mind that you don't miss the axilla. You have to. So just to be aware of it, you don't have to start from the axilla, but it's just to, you know, inculcate in your mind that axilla is must. Again, before you start ultrasound, make sure that you have looked at the mammogram. You're doing the which side. If it's lesion is on the right side, you're doing the right side. So make sure that you review mammogram, correlate, and obviously when you're scanning, ask the patient, where are your symptoms? Where are you feeling the lump? It could be what you are seeing on mammogram may not be there on the, may not, it's not the lump patient has felt, she might have felt something different. So, always. Same thing goes with the, what we were looking at, the mammogram quadrants, lesion, ill-defined or well-defined lesion, single or multiple lesion, size, shape, and axillary assessment. Now, I will just, so this is what we ultrasound we do. Now, to complete the case, if suppose if I uh, if you have given a mammogram, you will again start standard 2-view mammography, MLO and CC views. You will explain the abnormality in the right breast upper outer quadrant with prominent looking right axillary lymph node, no skin thickening. So when you do ultrasound, obviously when they will give you the images, you will have a skin marker or the body marker on there. So you will probably have a look on there that which area was scanned. So you'll say, corresponding to the abnormality seen on the mammogram, there is ill-defined lesion in the upper outer quadrant of the right breast. And on ultrasound, it's probably easy to say use clock phase. So you can say it is at 10 o'clock or 11 o'clock. There is no associated skin thickening, no other lesions in the given images. You may not get all the images for the ultrasound in the exam. So you say no other lesions noted in the right breast. and the axilla it looks normal, or there are prominent lymph nodes. Now sometimes different places have different protocols, but in UK they normally use the cortical thickness of the lymph node. So again, if there is a lymph node and you've got a hilum, so this cortical thickness, some places use 2.5 millimeter, some use 3 millimeter as a cutoff. So they just use this as if the lymph nodes are involved sonographically. No, it, obviously this doesn't mean they're involved histologically or pathologically, but this is just a criteria to decide if you're going to do a biopsy from the lymph node as well or not. So these are the basic guidelines. The how you differentiate between normal and abnormal lymph nodes. Obviously, the normal lymph node is more ovoid. It has a nice fatty hilum. It has cortical, thickness is preserved in all. It's not, abnormal. Abnormal lymph nodes will be more rounded. There will be loss of normal fatty hilum, so that you won't see this fatty hilum. And sometimes you have a lymph node which is partially rounded, but then you see bulges like so. You worry about these kind of lymph nodes. So these are the main features, how you differentiate between normal appearing and suspicious lymph nodes. I mean, this is just the axilla, but these principles apply to other lymph nodes as well. So just to be aware. Now, breast MRI, again, they may give you, if you're doing very well, they may give you the MRI. And I don't think they're going to ask you much in detail. The only things you need to be aware of in the MRI is probably the indications. So the indications, if there is discrepancy between your clinical findings, your mammogram ultrasound findings, then it can be used as the problem solving. Preoperative staging. Some cancers, especially lobular cancers, don't are difficult to spot. So you may need an MRI for further. Sometimes you assess axilla and you get metastatic lymph node from breast, but on mammogram and ultrasound there's nothing to see in the breast. So again, to look for the primary lesion, ultrasound with the MRI they use to assess response to chemotherapies. So you do MRI at the start of the therapy, then in the middle, and then at the end, just to see the response. High risk patients, so patients with BRCA1, BRCA2, or previous radiation to the chest, especially in young age, you do screening, MRI screening, because you don't want to give them the radiations. And implant imaging. So these are the general indications for the MRI. MRI guided biopsies, probably not many places do. I think where I used to work, they were only doing in Newcastle. No other centers did it in the Northeast. So these are again the inconclusive findings you can get in the imaging, and then you have to use the MRI. You don't have to worry about this. Again, I don't think they're going to ask you about MRI screening for high risk patients, so don't worry about this. How does it work in UK? The imaging, you probably know that all the screening mammograms are read by 2 breast radiologists. Obviously, if there's a discrepancy between 2 radiologists, then the third radiologist will have a look and then decide if you need to recall the patient or not. And and this is with the MRI as well. In UK, 2 radiologists read it as well. So with the mammography and MRI. Now this is the functional data interpretation, CAD they use for the MRI to look for the lesions. So the main principle with any cancer, especially breast cancer, the cancer cells have high mitotic ratio, so they will have more angiogenesis. They are obviously cells which demand more blood supply, they demand more nutrients. So whenever you will do the imaging, you will see that 3 curves. You will see these curves because with cancer cell, There will be angiogenesis, there will be more vessels forming, supplying nutrients to the cancer cells. So when you give contrast, there will be a sudden rise in the curve and sudden fall as well, and this is because of angiogenesis. So more vessels will be supplying, so there will be a flush of contrast going into the cancer cell region and then coming out quickly as well with the vessels draining them. So that's why if you have a sharp rise and fall, then these are most likely malignant lesions. So these three curves you just need to know. Type 1, you describe 1A, 1B, you don't have to go in A, B, just steady rise and it keeps on rising or slowly plateaus. The type 2, probably you'll see some in some of the atypical lesions, mostly benign again, uh, you know, it just straightens. But the sharp rise and sharp fall is because of the angiogenesis and high grade cancers, which will give you these kind of picture. Now, how do you, this is MRI report, don't worry about this. I mean, future um, of the breast, it's again, they're not going to ask you. Now, I will come out of it first, and if anyone has any questions, I can answer those before I go into the, some cases which I'll explain, and then show you further cases as well. So,
So if there is any question, you can ask in the chat right
yeah.
now.
So, yeah, someone mentioned lateral quadrants towards marker. I wasn't sure what that means.
Can you please explain your question once again, please? So there is a question about breast density. Can you read it, Asan, on
Yes, I
the
can
chat?
see it. Yeah,
Yeah. So
yeah, yeah. You can say A, B, C, D as long as you're sure that. The reason I don't tend to use these words in the exam is because examiner may not be using same, so it's best to say involuted, very dense, moderate, mild density, kind of those pictures which convey the message. You can use ABCD, that's no wrong with it, nothing, but try to be more descriptive, use words which gives the message clear. So in the exam, how to check adequacy of mammogram, good question. So in the nipple profile, especially in the MLO view, you should be able to see the nipple clearly, so just if I go back, give me a second. If I share, so I think you probably should be. So when you are doing a mammogram, this is, I'm just drawing the CC view. So this is the right breast, okay? So I've done the right breast. So the nipple should be in view. It shouldn't be, hiding like hair or, you know, going back or directed. So it should be straight, you know, ideally. This is how it should be. So if I draw it again, the nipple should be in profile, So this is how it should be. And then how you differentiate with the lateral and medial, someone was asking. So you draw a straight line back from the nipple. So the thing which is up, towards the upper end or cranially on this one, it's obviously you have to think about this as a 3D structure. So the area above the nipple is lateral, area below the nipple is medial. So this is how you differentiate. For MLO, as I said, you draw again, the nipple should be in profile clearly, and you draw the line going back. Anything above is upper, anything below this line is lower. So based on these, you can divide the breast into, you know, 4 quadrants, which are upper out upper outer quadrant. Sorry, upper outer. This is the right breast. Yeah, upper inner quadrant, lower inner quadrant, and lower outer quadrant. As I said, you can use clock face like 12 o'clock, 6 o'clock, 3 o'clock, 9 o'clock, but I find it difficult, especially in exam and even in clinics when you are under pressure, you're seeing a lot of patients and you have right and left breast, you may confuse things. So just saying right upper quadrant, left upper quadrant makes it things easier. So just to be aware of it. Okay. And okay, what's when they say PNL in characters mainly as for yes. So when you are saying characters mainly barrettes 4A, 4B, 4C, don't go in detail, just say 4. Okay, you don't worry about it. So now let me just okay, what does it mean when we say PNL in MLO? I'm not sure PNL. I haven't. Do you have the full details of this term because we never use this one. We don't take upper, lower, and CC views. Yeah, so CC views you don't take upper outer. You say lateral and medial. So posterior nipple line. Okay. I mean, we don't use this term. I haven't used this term when I was training in UK, so we don't use this posterior nipple line. I just want, as I said, keep for the exam purposes, just keep it simple. Don't try to go in uh, these terms because if they keep on asking you, then you probably will make things more difficult for you. Architectural distortion on mammogram and ultrasound. Okay, yeah, just give me a second. We are done. Okay, so many questions. Give me a second. So okay, now let me just go through. So these questions, when you're saying you're asking about the lesions, about how to manage B3. Again, if you see B3, this is a tricky one. B3 lesion, most of the, as per the guidelines, you do a follow-up imaging, especially ultrasound in 6 months' time. However, again, in the exam purposes, as we are talking about the exam purposes, you describe them as a either 4 and 5, and then you suggest ultrasound guided biopsy because you have to close that loop. So this is what I is it mandatory to do ultrasound if mass is palpable? Yes, yeah. So yeah, you have to do ultrasound. Obviously, if the patient is coming at again, even if they are below 40 or above 40, you have to do ultrasound. So ultrasound is compulsory. Okay. Now are there any other questions before I go into the okay? If the lesion is clearly malignant on mammogram in the is it enough to say ultrasound guided biopsy? No, you have to do ultrasound. Ultrasound is part of your assessment. So and again, use buzzwords, triple assessment. How you're going to do those assessments? So you have to be clear. Do the mammogram, do the complete ultrasound, axillary ultrasound, because axilla, you can only assess axilla adequately on ultrasound. You can't do it on the mammogram. So you have to do ultrasound, and then based on the ultrasound findings, you will suggest. So what we will say is malignant appearing mass in the right breast. I will go perform the ultrasound, and then when you see a lesion on ultrasound, you will explain that lesion, and then you'll say I will proceed with the ultrasound guided biopsy of the breast lesion. And then obviously nowadays it's very common to put a localization clip in the lesion. So you have to mention that I will be inserting a localization clip in the biopsied mass. And once you put a clip in, you have to do a post marker check mammogram as well. So just to be aware of these, new modalities or new procedures coming in. Okay, now if I go back and share the screen, so
Candidate one, are you with us?
Yes, I am.
yeah,
Okay, so over
so
to you. Over to you.
so yeah, so just start with this. So this is a patient who is coming in with feeling some pain and discomfort in the right breast.
Okay.
Yeah.
I can't see anything on this. Like there is only your name, Dr. Salim.
Can't you see the? Can you see now? Is it, or
No, I don't know if anybody else can see because
let me
I
check.
can only.
I
Yeah.
was sharing the screen.
And we cannot see your screen right now. I'll tell
Okay,
you when I see it.
okay. Give me a second. Can you see now?
Yes. Yeah.
Yes. And if you can go into yes,
Yeah.
fine. Over to you.
Mhm.
Yes. So can I just have the history one more time? Sorry.
So this is the patient. Just give me a second. Here she is, 53, recalled after screening mammogram. You know, I mean, just treated as screening patient first.
Okay, so this is a standard two-view mammogram of cranial and mediolateral oblique.
Mm,
What caught up my eye is this increased density in
mm,
the right retroareolar region in the
mm,
craniocaudal, which also I think it is kind of central to lower half or quadrant.
mm,
Because it's retroareolar, I think I can't really pin it to one quadrant. And this increased density, I would zoom it in normal practice to see if there's any pleomorphic calcifications.
mm.
I,
There you go.
I don't think there's any pleomorphic calcifications.
Mm,
Um, on the other side, which is the left side, I can see also some
mm,
increased density.
mm,
But I think that this both areas, retroareolar areas, are asymmetrical, but I don't see any architectural distortion. And I think the breast is mostly fatty with some scattered
mm,
glandular breast tissue, retroareolar.
mm,
Um, I think if I was looking at this in my normal practice in the screening pile, I would regard it as normal or no change, no suspicious change suggestive of any malignancy,
mm,
and I wouldn't recall the patient.
mm. So, you started well by saying standard 2-view
Okay.
mammography in ambulance CC
Yeah.
views of both breast, and you picked the abnormality. So I'm saying abnormality, the reason this area, retroareolar. So there is
Yeah.
asymmetry, on the right and left, you see.
Yeah.
And if you don't have any previous mammograms, there were no previous, first, then I think I will probably treat it as suspicious, there is.
Okay.
Okay. So this,
Yeah.
this maybe the left might be just a glandular tissue, but this one is slightly more prominent, slightly more denser than the right, asymmetrical. So, but the other thing, obviously, when you started, you should have said, mentioned the breast appear fatty. So they are fatty breasts. There's not much glandular tissue.
Yeah.
So, so you will probably, agree. You will probably call it, screening. You can call it M4, or you can call it back for further ultrasound assessment or triple assessment. So,
I
so,
see.
so, but don't worry about it. Anyways, I don't know if any of you can see, but um,
Yeah. This is like a dense. Oh, there's.
give me
Oh.
a second. Yeah, give me a second if I
Okay.
can. Yeah. So yeah, go on. I will just try to start it and then concentrate on the left side. Okay, just.
Okay, I just can't see the annotation from the Zoom.
Mhm.
I mean, I don't know which one is right and which one is left.
Okay, can you
Oh,
see now? Yeah.
there is no annotation on the screen, but okay. So,
So I mean, what
so
what can't you see? Sorry, what can't you?
the annotation, like which is right and which is left. Shall I
Yeah,
just
this will
assume
be
that?
your right. Yeah, this will be right.
Okay,
This will be left. And then
okay,
when you see these pectoralis muscle, then it is MLOV. Okay. I know it's not very
yeah,
good quality, but remember, all the patients come. They don't, they are not. All the patients are not fit and healthy. They are not, can't move their
yeah.
arms above their head, and mostly, yeah, patients in their 50s and 60s and 70s. So yeah, you have to give something. So yeah, go on.
Okay, so I'm again presented with a standard two-view mammogram of craniocaudal and mediolateral oblique of
Mm,
both breasts. I can appreciate that both breasts are dense glandular breast tissue.
mm,
on the left craniocaudal
Yeah.
view
Mm.
and midulateral oblique, I can see scattered diffuse polymorphic calcifications. It is mostly on the upper
Can I
on
just stop
the
you there? Sorry.
sorry.
When you say
Yeah.
scattered and diffuse, scattered means
Yeah.
spread out. Diffuse is more together, in one region. So when you use those words, you have to be careful. You can just say there's a diffuse you know, or
So
group
okay.
microcalcification. This is more group. Just scattered means more some in this region, throughout, spread throughout. So it will be more grouped microcalcifications.
A
Okay,
grouped, sorry, a grouped
grouped,
or
yeah,
is it
grouped.
okay?
GROUPED, grouped.
Yeah,
So
yeah,
it's
yeah.
more, yeah.
Grouped. Okay.
Okay.
So it is in the upper half in the craniocaudal.
Mhm.
Um and the midulateral oblique, I can't appreciate them properly, but then it
Yeah,
looks
it's very difficult. It's this region. I know it's not very good quality mammogram, but this is here in
all
this
right,
region.
okay.
Yeah. If I,
Yeah.
yeah, this is
So
sorry. Yeah, here they
yep.
are. Mhm.
Um
Mhm. So this is
I
this is just screening patient. So how would you complete this full case? So,
so is this density that I can see within the grouped calcification uh, so I think these are concerning features, and I would recall this lady back to the assessment clinic to have an
hmm
ultrasound assessment.
hmm
And then if this shows any mass, I think I would proceed with examining the axilla on the same side,
hmm
as well as considering ultrasound biopsy, core biopsy.
okay. If you don't see a mass,
Um, we can't see a mass on the ultrasound.
yes. If you don't see a mass, I'll just.
So I see. So then I think a stereotactic biopsy using mammogram for this area of concern
hmm
would be the way to proceed.
hmm
If that comes back as B1, which is like histology normal,
hmm
I think then we can consider a contrast enhanced MRI or contrast enhanced mammography to make sure that this area is actually hyper
hmm
enhancing in relevance to the rest of the breast.
Okay, give me a second. I will explain. Just give me a second. So,
Okay.
so it was good. So you will say this is standard 2V mammography ambulance CC views of both breasts.
Yep.
Fairly dense heterogeneous glandular tissue bilaterally, making assessment limited, which it does. Obviously, it's quite dense compared to the previous mammogram. If you look at the last one we saw, very
Yep.
fatty. So you can see, and you pick the micro. So there are group microcalcification in the left breast. Again, it's probably more behind the nipple area and more lateral, so difficult to pinpoint. But you can say in the lateral compartment of the um, left breast, or probably upper outer or lower outer quadrant of the left breast.
Yep.
I will recall this patient for further triple assessment in our clinic. So we will offer her an ultrasound. We'll scan her with ultrasound. We'll assess the breast and the axilla. And if we see any lumps in the left breast, then we'll take a biopsy through it and insert a localization clip. And at the same time, if there are any abnormal axillary lymph nodes, we'll assess them with the ultrasound guided core biopsy. However, if we don't see any lesions on ultrasound, patient will have a stereotactic guided biopsy of these areas, making sure that we get microcalcifications in our specimen. And you will x-ray the specimen, you will insert the localization clip, you will do the post-marker check mammogram. So this is how you complete the assessment. Yeah.
I see.
Yeah. And if, as you mentioned, histology comes back, you don't probably directly jump into the MRI, you probably do a rebiopsy, because these look fairly, malignant calcifications, fairly suspicious. So rather than jumping into the MRI or contrast enhanced straight away, you probably offer a repeat biopsy, you know,
Okay.
and then obviously
I repeat biopsy using ultrasound.
ultrasound, or probably I think stereo would be better. Like, if you don't see it in first place, you don't,
Okay.
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 Case 3. So let me just have a look. Don't worry about this one. Yep. So again, this is a patient. Don't worry about. I'll change the history. So she's a 53-year-old lady coming with some discomfort. She went to her GP, and the GP felt some vague, you know, changes in the right breast.
So this is a standard 2-view mammogram of cranial mediolateral oblique of a breast that shows a scattered granular breast tissue.
Hmm.
The obvious or the abnormality that caught my eye is an increased density in the right upper outer quadrant. It is well defined with some spiculate margins and architectural distortion. I would zoom in to see if there is any polymorphic calcifications. Um, the axillary fold, I can't see any enlarged lymph nodes in the axillary fold. How I would proceed with this mammogram is that this patient needs an ultrasound of the upper outer quadrant, and I think this looks suspicious, so I would examine the axilla as well,
Hmm.
and any lymph node cortical thickness beyond 3 needs biopsying as well as biopsying this mass.
Hmm.
I think this mass would be visible on ultrasound, so I would proceed with a core biopsy
Hmm.
and put a
Hmm.
marker pin in. Then I think she needs to be discussed in the MDM for further
Hmm.
management.
Okay, good. So again, you're slowly improving. The thing, you don't do ultrasound in the upper outer quadrant. You do ultrasound the whole breast. Okay, okay.
Okay.
Just make sure. Okay. Uh, I think it's a good practice. Patient is there. You just don't want to miss anything else. So you started, well, standard 2-view mammography, MLO, and CC views, including tomosynthesis, um, involuted breast tissue or fatty breast tissue, and as rightly mentioned, there is ill-defined opacity or in the upper outer quadrant of the right breast. So, and obviously you can't see any lymph nodes on the mammogram, but again, it's not diagnostic for them. The left breast appears intact with no focal microcalcifications, architectural distortion, or lesion. So, just try to phrase it or just try to make your own, quick reports and try to memorize them. So in exam, you just go through. So like normal reporting, I would be just quickly standard 2-view mammography, MLNCC views, including if there is tomosynthesis. If not, then obviously you don't mention of both breast. No previous imaging for comparison. Scattered fibroglandular breast tissue, full stop. And then you say ill-defined opacity in the right breast upper outer quadrant, no associated microcalcifications or skin thickening or nipple retraction, full stop. Left breast appears intact, and no abnormal appearing axillary lymph nodes within the limits of mammogram. And so for further, I will proceed with the ultrasound of the right breast, and then you explain the findings corresponding to mammographic abnormality. There is, you know, ill-defined lesion in the upper outer quadrant of the right breast, highly suspicious for malignancy M5, U5. I will proceed with ultrasound guided biopsy of this lesion and insert a localization clip. At the same time, I will assess the axilla as well to make sure there are no abnormal appearing axillary lymph nodes. And then you said the right thing. You will refer the patient to the. If it's a symptomatic clinic, you will probably the patient will go and see the surgeon straight away, or there will be breast care nurses. And you rightly said MDT discussion as well. Okay. Okay. So yeah.
Um,
Mhm.
yeah.
So
About scanning the whole breast, is that because it's an assessment clinic or
I
because
mean, it varies again. You see, I know there's. You work in Northeast, do you? No.
I do, yes, I work in
Yeah,
Newcastle.
I know. I thought
Oh
you're
yeah,
already a consultant.
I think we met when I was an ST3. Yeah,
I don't know. Okay.
in
So
Northeast.
yeah, yeah, I know.
Yeah, I
Um,
think because
mhm,
we were told that the
mhm,
it is a
mhm.
targeted ultrasound, and if we scan the whole breast,
It
we might
varies
still
from
see.
place to.
Yeah,
Yeah, I know.
yeah,
It varies from place
mm,
to. I know in Northeast we do targeted. You can say
okay,
target. Especially in this fatty breast, you probably do targeted. But if
right,
it's more dense heterogeneous breast, you may not see all the things. Then you probably, I think, it's best because this is a change in practice. I have experienced myself in UK. We were doing more targeted. In Saudi we do more. Uh,
whole breast.
for both, yeah, whole breast. So
All right, okay.
okay. Anyways, so yeah, so we'll take the next candidate if that's okay.
Thank you very much, Dr. Salim.
Sure. Thank you. Thank you.
Hello, Doctor.
Hi. Hey, give me a second. So yeah, someone is asking ultrasound guided biopsy clips. Yes, they're done in the same setting. Yeah. Adequacy, you can, do we need to tell adequacy of the mammogram? Yes, if you can. If you can, do we need to tell about it again? I'm not sure which case Dr. Maya is asking, but I think they were malignant. M4, no, M4 is not equivalent to Barrett 0. So M4 is Barrett's 4. Yeah, okay. Candidate 2, give me a second. I'm just going to see. Again, it's not very well projected, but let's see if you can. Okay. So I don't know how good can you see, but this is a patient who is coming for assessment after feeling pain in the breast, and she has a diagnosis of previous lung cancer.
Okay. Unfortunately, I can't see the screen.
I've shared it again. Is it not coming through? Give me a second. Can you see now?
It came up and it's come off again.
Can you see now?
I think it's sharing. Yes, I can. It's just not in the presentation mode.
Now?
Yes, I can see it now.
Okay.
Okay. So I'm presented with MLO and CT views of both breasts. The breasts are predominantly fatty, so I'd grade this as a grade A. The first thing to know is I can see some asymmetry on the left side in comparison to the right, in terms of the shape of the breast. I'm looking for any other associated features, such as any discrete mass or any architectural distortion, which I don't see anything obvious on both views. I'm looking for any skin thickening. I don't see any obvious skin thickening, although it could be just the view that I'm seeing. I think on the left breast, there's maybe generalized skin thickening in comparison to the right. I don't see any microcalcification, and I don't see any obvious large axillary lymphadenopathy. So overall, this is with a patient with background of lung cancer, I believe. Is that right to say?
Yeah.
Yeah. The findings on the left could be, I'll be thinking about whether this could be a generalized a mastitis type picture, or whether this is related to any previous chemoradiotherapy. So in the first instance, I would compare with any previous imaging if available to me. I would also perform a ultrasound just to confirm our findings, to look for any skin thickening, and refer the findings to the breast clinical team, MDM, for further management.
Yeah, I think, I don't know. Sorry, I missed that one. Did you mention about the axilla? Did you say? I think
I
it's
did
not very
I
project.
clearly love
Yeah. I think it's not projected. That's why I initially said. But if you look at this, probably increased density. In the region here, in there. I don't know. It's difficult to appreciate, but this area here.
Okay. Yes, actually, probably now in retrospect, I can probably see that.
So that's the reason. Again, so obviously with this kind of picture, you have to, it's an ultrasound. I think the left side was essentially normal. It's not very good mammogram, I have to admit. But this is the area in the right axilla. Again, your differential could be just a metastatic occult breast cancer with axillary lymphadenopathy, or it's given the lung cancer, it could be just the mets from the lung cancer. So you do ultrasound and all the assessments. You still follow the same steps, okay? You don't change your steps.
Yep.
Okay, give me a second. Don't worry about this one. Again, not very good picture, but can you see it? If you can, I'll see. This is the CC views for this as a screening mammogram, and that's the MLO. So
Okay.
have a
So
look, and yeah, have a look first, and then I'll show you the MLO, and then you can start. Okay.
okay.
Um,
On the
yeah.
on the MLO views presented of
Mm,
both breasts, it's first thing to note is that there is increased fibroglandular breast parenchyma, probably keeping with a type D, which
yeah.
reduces the sensitivity of finding
Mhm,
occult lesions.
mhm,
On the MLO view, I can see on the right side
mhm,
some slight increased density in the
mhm,
lower half of the right breast. I'd like to also look at the C.
mhm.
Um,
Yeah. Can you see
I
it
don't.
now?
It's not really projecting. So I mean, I could see
Mm,
some possible calcification in the
yeah.
upper half of the right breast.
Mhm.
I would look at CC views. On the CC view, I can see that these
Yes.
calcifications
Oh, again,
are
sorry, just rescans. Yeah.
these calcifications on the
Mhm,
CC view in the
mhm,
right sort of lower quadrant is
mhm,
slightly diffuse um, uh, in nature,
mhm,
and it's sort of long segment.
mhm,
In my normal practice, I would ask for further views, maybe further lateral views to just exclude
mhm,
any obvious T cupping.
mhm,
Um, and if this patient's in screening, this patient would be recalled back
mhm,
um, and would do lateral views for confirmatory findings. If there was no T cupping and they looked more pleomorphic,
mhm,
then the first thing to do would be to perform potential an ultrasound to see if we can see these calcifications
mhm,
and potentially do a biopsy if they are available to be seen, and insert a marker clip. Alternatively, if there is no calcification that can be
mhm,
identified on ultrasound, then I'll take this patient to a stereotactic biopsy and
mhm,
perform the necessary and insert a marker clip and
mhm.
refer these findings to the multidisciplinary team for the
Good.
management.
Yeah. So when you were explaining, you picked the findings, and when you said more segmental, more pleomorphic, then you don't have to do these lateral views, because lateral views, if you're not sure, but if you're already using words like segmental, pleomorphic, and you know these are malignant, you know these are more in segmental. So DCIS, ductal carcinoma, and situ in that pattern, it goes along the duct. So um, so yeah, just try to be more authoritative. Yes, these look malignant. Okay, don't have a doubt. But yes, you're right. Otherwise, you will do stereotactic. I think when I was doing the last candidate, obviously when she mentioned targeted ultrasound. Now, there's always a way out of it. Obviously, practices are different everywhere. So, even if you're coming outside UK, your practice will be different. So, you always say that in our routine practice, we will scan the whole breast. There's no harm. Or you can say in our department where I train, we do the targeted ultrasounds for the lesions. So there's no harm in mentioning that. As long as you're doing ultrasound and you're safe and you're not missing anything, then you will pass.
Okay.
Okay, so let me see if there's any. So these were the microcalcifications. Okay, so they look
Okay.
fairly malignant. Okay, that's fine. I'll probably change to the other candidate if that's okay with you. Yeah.
That's fine. Yeah.
Let me share. Okay, any more questions? There are two questions. What the Barrett's category for the last case? It'll define irregular. That will be 5. 5 and the M5. We also scan whole breast and ultrasound in Bangladesh. Yeah, I mean, it varies from place to place. It varies. So yeah, I think. Okay, so next candidate, if that's okay, and I'll show you the case. Yeah, can you see the next end? Hello, can no barriers don't work on axilla. No.
Good evening, sir.
Hi, good evening. Good evening. So yeah, I couldn't hear you earlier. Screen. Okay. So give me a second. I will just go to the screen sharing. Now, can you see the screen now?
Yes, I can.
Okay. So the history is there. Again.
The screen is not shared.
No, it was sorry. It disappeared again. Yeah. Can you see now?
Yes, I can.
So start as if you are doing the full mammogram. I know the images are only on the left, but you just do it as you're doing a full case. So we assume the right side is normal, but still do it as a full case. Okay.
Okay, sir, but when you press on the full zoom, it's gone.
Okay, why it's going? Is it gone again?
Yes, it's gone.
Not sure why it's happening.
So I'll tell you when we can see your screen. Right now, we cannot see your screen.
I don't know why it's doing this. Can you see now?
Yes.
Okay. Okay. So yeah, the history is there. 39-year-old female with palpable lump for 3 weeks in left breast. Okay.
I have been provided with a standard MLO and CC view of the left breast.
Mhm.
The breast looks glandular, grade B. I can see that there is well circumscribed mass lesion seen in the upper quadrant of the left breast. On the CC view, I can see it is a little bit within the center, so most likely within the outer aspect. The mass lesion showed well circumscribed border, and there is no calcification seen within the mass lesion. There is no architectural distortion seen around the mass lesion. There is no skin thickening. The nipple is seen within the profile, not inverted, and I cannot see any pathological axillary lymph node enlargement. In my routine practice, I also will use the zoom to magnify this image to look for any microcalcification within the mass lesion or elsewhere within the left breast.
It's good. So, we have seen the other mammograms as well, which were very fatty, which were very dense. So this one, I won't call it D. There is some fatty tissue. In this region, this is quite fatty. So probably I will call it C. I won't call it.
C. Okay.
D. Okay. Now you explained it right. This is ML and CC views. There is a well defined, rounded mass in the upper quadrant of the left breast, which is more central. But you have to mention that it's only partial or partially imaged or partially obscured on the CC view. So it's not complete. Could be this patient is elderly. She have some issues. They can't, bring the whole breast into the mammogram. So these issues can happen. So but you explained everything. The nipple is intact. It's not retracted. There are no microcalcifications. There's no skin thickening, no axillary lymphadenopathy. So that's good. So what would you do next?
This looks like a benign lesion,
Mm-hmm.
BIRAD 2.
Mm-hmm.
However, I will compare with the previous images if available to see if this lump showed any increase in size. And
Mm-hmm.
I will do ultrasound for this patient and
Mm-hmm.
will complete the study by doing axillary lymph node ultrasound. Okay,
Okay.
this mass lesion in the ultrasound appears well defined,
Mm-hmm.
hypoechoic, and
Mm-hmm.
show acoustic enhancement. There is
Good. Yeah.
no acoustic shadowing, and
Mm-hmm.
the mass lesion measuring about 27 millimeter,
Mm-hmm.
and there is no uh, uh, acoustic shadowing is noted within the mass lesion. In my routine practice, I will also do color flow to see the pattern of the color uptake within this mass lesion. This
Mm-hmm.
mass lesion looks benign, so I will complete the ultrasound for the rest of the breast, and I will do axillary ultrasound too.
Okay. So what's your first of all, when you said you will do that color Doppler? Now, when you said this, examiner may ask, okay, tell me different types of color Doppler you will see in a breast lesion.
Yes, there is two types of color uptake. There is the peripheral and there is the central.
Mm-hmm.
The peripheral is usually goes with the benign lesion, and the central is usually seen within the pathological malignant lesions.
Okay. So on your assessment, what do you think it is?
It looks like fibroadenoma.
Good. So again, here come the guidelines. In UK, if this patient is above 30 years old and they have this well-defined lump, which you think is a fibroadenoma, it's a benign, but they will still do a biopsy. Okay.
Okay,
So just to be aware, so just go through the guidelines, local guidelines. In some places, BIRADS 2, they will probably just say follow up. Okay.
okay,
Uh, in so in the UK, I'm just talking of, obviously I'm not going to go into American or Canadian guideline stuff. From UK purposes, yeah, it looks benign, but she's above 30 years old. It looks like a fibroadenoma, but you will do a biopsy. If patient is young, it's probably suppose she's 21 years old, then you'll probably follow up with ultrasound. You won't do a biopsy, but the guidelines are clear. And so, again, in some hospitals, the cutoff for the biopsy in benign looking lesion is 25 in UK, and some hospitals is 30. So these are two ages. So just keep those in mind. Okay.
yes.
Okay. Just give me a second. I'll just check if there are any questions, and then we'll go to the next. Someone is incomplete imaging M0. Yes, incomplete imaging is M0. That's fine. Okay. Second. Can you see it? No, not yet.
Not yet.
Still no? No?
No.
It's doing this. Yep, here you go. So this patient had a screening mammogram, 55-year-old. And these are, can you see it?
Yes, I can see now. No.
So these are the MLO views. MLO is not complete, so I've done, kind of a more, but these are, so just take your time, don't rush, just look at them, make up your mind. So when you're ready, you can start.
Yes, I have been provided with the standard CC and MLO view for the
Mm-hmm.
left breast. The breast look fatty. There is
Mm-hmm.
a few glandular areas seen in the retroaurial region. I can
Mm-hmm.
see that there is scattered calcification noted mostly within the outer aspect and upper aspect of the left breast.
Mm-hmm.
The calcification appears rounded and fine in size. They are
Mm-hmm.
not looks like microcalcification. I can see that there is no skin thickening, and also I cannot see the nipple in profile. However, I don't think this nipple is inverted. I will continue by reviewing the other views for this patient,
Mm-hmm.
and also I want to see the previous images if available. This
Okay.
calcification
Mm-hmm.
looks like a benign calcification rather than
Mm-hmm.
malignant calcification.
Mm-hmm. So do you think it's a normal or abnormal?
Uh, because this calcification,
Mm-hmm.
uh, yes, this could be um, um, this is not a skin calcification. They are not artifact. They
Mm-hmm.
are within the breast itself. And in my routine practice, I want to zoom to see
Mm-hmm.
the nature of this calcification.
Okay. So I'm drawing this for you. Can you see any difference here?
Yes, I can see that there is obvious density seen in the left retroauricular
Mm-hmm.
region.
Mm-hmm.
This density is causing some sort of
Mm-hmm.
articular distortion in the left breast. So
Mm-hmm.
in this area, I will zoom
Mm-hmm.
to see, and I will correlate with the patient history to see if there is any history of previous surgery.
Mm-hmm. Give me a second. There you go. You got zoomed in.
Yes, I can see that here is well-defined large calcification with
Mm-hmm.
central lucent zone.
Mm-hmm. Okay. What's
Okay,
other abnormality? Yeah.
other skin thickening.
Yeah, skin thickening and some soft tissue, subcutaneous say soft tissue thickening as well. Yeah.
Yes,
So
yes,
when we were looking at it, give me a second. So that's why I was showing you again this, So it looks normal on the right. There's something going on the left.
yeah,
Now you have to correlate with patient's history. She may, because when they come for screening, you don't have any history, much history. Sometimes the mammographer doing the mammogram may write patient has a trauma, or she has an abscess, or she's got a nipple discharge. These kind of things they may write on the sheet, but you don't always get the history in the screening. So yeah, so with this one again, you have to be a bit more. Okay, so this is the ultrasound they did for that breast and axilla, same
yes,
patient. Hmm.
yes. This is breast ultrasound images selective taken
Hmm.
for the breast and the axilla. On
Hmm.
an axilla, I can see that there is um, lymph node
Hmm.
measuring about 3.3 millimeter,
Yeah,
and
cortical thick, not the full lymph node, the cortical thickness. Okay.
the cortical thickness, yes. I think the cortical thickness is more than 2.5
Hmm.
millimeter. So
Hmm.
this could be a pathological lymph node.
Yeah.
On the other, yeah.
Hmm. Yeah,
On
go
the
on.
other
You're
image, I can see that the breast skin appear
hmm.
thickened,
Hmm.
and I cannot see any definitive mass
Hmm.
lesion or abnormality within the left breast.
Hmm. Yeah. So you said, probably the abnormal lymph node. So you'll probably do the lymph node. You'll definitely do the lymph node biopsy and then correlate if it's, from the breast or not. If it is, then you have to, further investigate with MRI. So this is how you complete the whole loop. Okay.
Mhm.
Good. Give me a second. Just give me a second. So you will do this one more case and then go to the next candidate.
Okay.
Okay. So check. questions. Let me just. What will bilaterals for axillary? You normally don't do, bilaterals for axillary lymphadenopathy. But what is the pathology in the left breast? I'm not sure which case you're talking about, but ultrasound guide. Okay. Okay. So I will go through with the BIRADS and the guideline ultrasound. So again, as I said, BIRADS slightly different. American system is slightly different to UK. So again, when we are just discussing UK, so probably I think it's best not to confuse, both. So in UK, you will just say M1, which is negative for malignancy, M2 benign, M3 likely benign, M4 likely malignant, and M5 definitely malignant. Okay. So these are the categories for the BIRADS. The ultrasound thing, what is the guidelines for ultrasound? Again, you do ultrasound, when you're doing most of the cases you will get in the exam, you obviously, if they have pathology, you have to do ultrasound. If you look at the mammogram, even if the mammogram is normal, but patient is feeling a lump, you have to do a ultrasound. So the ultrasound you will do to assess the breast and the axilla, and then again you classify them 1, 2, 3, 4, 5. Again, as I mentioned, that in UK, there's even if it's a benign appearing lesion, if you think it's a fibroadenoma, you still do the biopsy. In some places, age cutoff is 25, in some places 30. So, you do take a biopsy. BIRADS, last BIRADS, I'll probably say the one with the left-sided retroareolar, the skin thickening and edema, I'll probably call it M4. And thickness of the cortex of lymph node. Yeah, if lymph node cortex is increased and you have some suspicious features like skin thickening in the retroareolar region or abnormal, then you do the biopsy first. You proceed with MRI, because if you are not seeing any lumps in the breast, then you have to assess the breast with MRI. So you do biopsy first of the lymph node. If it's positive, then you discuss in the MDM or MDT meeting, and then take second biopsy before MRI. I mean, it's not compulsory, but obviously it's more in discussion with the local team. So if first biopsy, if you're suspecting something is malignant and your pathological and radiological and clinical findings don't match, and as a radiologist you are suspicious, then it's your call. So ideally you should. It can be Paget's disease. Yeah, someone mentioned it could be Paget's disease of the nipple. That's fine. Indication of MRI I shared, but I'll do. So in UK, we prefer biopsy, not FNA. Okay, FNA only for the lymph nodes which are very tricky. In a way, they are very close to the vessels, and you have a risk of damaging the vessel. Only then FNA. Otherwise, in UK, it's biopsy, biopsy, and biopsy. Skin biopsy, yes, skin biopsy in UK is mostly done by the punch biopsy, mostly done by the surgeons themselves, so they can do the skin biopsy. Staging CT, no, staging CT, again, it's a MDT decision. So again, there are local guidelines. So when I was working, there was Northern Alliance guidelines. So they have specific points, and again, they vary. So CT guidelines are different everywhere. So you don't suggest straight away. If patient over 30 years has benign looking mass, will you give it M2 and still? Yes, even if patient is above 30 and looks benign, it looks like a fibroadenoma. In UK, yeah, you still do it. Biopsy, yes. In UK, I'm talking. If it's M5, can we suggest CTA? No, you can't suggest. If it's M5, don't worry about CT. CT will be more discussion after the MDT. So, don't worry about it. Okay. Was there nipple in last case? It was difficult to see. The wasn't clear in profile. So, anyways, going to the next case. Was there in okay. Someone is asking about next steps. So obviously, if the biopsy is positive, then you do an MRI for that, breast. Yeah. Can you see it now, this case?
Yes, I can see it. Yeah.
Okay, so this is the MLO view and this is the CC view for this patient. Okay. Just have a look before you start. I will, and then if you want to leave me MLO view, I will leave it for you. If you want to concentrate more on CC view, I will leave CC view for you.
Okay. I want to start with the MLO view.
Mhm.
Okay. I have been provided with a standard MLO
Mhm.
view and CC view for an adult female patient.
Mhm.
I can see that there is a granular tissue and fatty tissue within the breast. I can see that there is opacity noted within the upper outer of the right. Yeah, here I can see that the opacity is in the retroareolar
Mhm.
region, and in
Mhm.
the MLO view, I can see it in the upper quadrant.
Upper corner. You can't see outer on the CC, just say upper. Sorry, on
Yes,
MLO,
yes,
you can only see upper MLO.
upper,
Okay.
yes.
Mhm.
Here in the retroareolar region, I can see that there
Mhm.
is soft tissue, yes, opacity. This soft tissue opacity appears
Mhm.
ill-defined and it is indistinct.
Mhm.
This lesion is
Mhm.
causing architecture distortion. In my routine practice, I will use the zoom ability to see if
Mhm.
there is any associated grouped microcalcification within this mass lesion. Here, after the zooming, I cannot see or appreciate any microcalcification within the lesion itself. There is no skin thickening, and I can see that there is no nipple retraction. And in the MLO view, I can see that there is lymph nodes.
Mhm. Mhm.
The lymph node appears not pathological.
Mhm.
Uh, Okay, and I can see that there is another smaller opacity also noted inferior to the previously mentioned one.
Mhm.
So I'm dealing with two opacity lesion in the right breast. In my routine practice also, I will
Mhm.
use the mag view. Yes, yes,
Mhm.
truly. In my, I want to use the magnified view, and yeah.
Yeah. So, again, you use the terms, don't use soft tissue opacity,
Uh,
Cancer is, it may be heart cancer, soft tissue, how can. So just say there's a ill-defined opacity partially obscured in the upper um, upper quadrant on MLO view and in the retroareolar region in the on the CC view. Okay. Now, if I tell you, so these are the mammograms, different. So this one is for the same patient, 2017 and 2014.
okay. Um, on the one on the right hand side,
Mm-hmm.
I can see this is a recent one, 2017 on the right hand.
Yeah.
Yes, I can see that the opacities are now decrease in size
Mhm.
in comparison with the previous image,
No, So,
and
so this is
also
one. This one is the new one. Sorry, this is the new one. This is the old one.
ah, so in comparison, the new one showed
Mm-hmm.
the opacities. The new opacities are not visualized within the 14 image. It is now in the recent image. I can see the new lesions. So
Mm-hmm.
in my routine practice, I want also to do ultrasound
Mm-hmm.
for the right breast,
Mm-hmm.
including axillary lymph node. I'm looking for any signs of, yeah, I can see that there is hypoechoic lobulated mass lesion. This mass lesion also showed angulation. On the other image, I can see that the mass lesion is not showing any acoustic enhancement, and there
Mm-hmm.
is also no acoustic shadowing is noted. The mass lesion is measuring almost 14 millimeter. And
Mm-hmm.
in my routine practice, I will also do color Doppler to see what is the color uptake for this lesion. This lesion looks malignant. I will continue the imaging of the rest of the breast, including the axillary, and I will proceed to do biopsy.
So you will proceed and do ultrasound guided biopsy, and what next?
Next, I will do.
So when you do a biopsy, I don't know if you got. So when you do a biopsy, obviously you put a small clip in,
yeah.
Yeah. The reason you put clip, because if this patient is going for new adjuvant chemotherapy, the lesion may shrink and it may disappear. And when it disappears, you may not be able to see the lesion in follow-up imaging, but at least you will have a clip. And then you will refer this patient to
MDT team.
MDT, a multidisciplinary team meeting. Okay. So yeah. So this is, you described it right. This is probably slightly indistinct, ill-defined margins of this lesion, which is hypoechoic. There's no posterior acoustic enhancement, probably some shadowing in this region. Appearances are highly suspicious for malignancy. You will proceed to ultrasound-guided biopsy. You will insert a clip and then refer the patient to a multidisciplinary team meeting. Okay. Okay, that's fine. Yeah. So if we can get the next candidate, please, if that's okay.
Thank you, sir.
Thank you. Thank you.
Hello.
So hi. So we insert clips in all the malignant lumps. I think we insert in all the, nowadays you insert in all the biopsies you do. You insert the clips. So this is our practice nowadays. All. Okay. To investigate multifocal and multi-segment mass spectral invasion extent of cancer, especially in yeah, MRI is better. That's fine for maybe. Okay. Next one. Okay, let me just see if I can. Yeah, can you see?
Yes, I can see.
Give me a second. So just have a look. Don't rush. This is the most recent mammogram. Okay.
Mm-hmm.
So you've got. Don't worry about the right side. We assume it's normal. And then this is again the current mammogram. So and then the left. I think the images. Yeah. So we start with the most current mammogram. Okay. So you start with the left side. Sorry.
Okay.
Okay.
So I'm presented with the standard two views of mammography with a CC and an MLO. So right off the bat, I can see an ill-defined irregular density in the upper quad, in the upper half of the breast. And then on the CC view, I can see it's directly in the posterior nipple line. So it might be, I know we don't use the clock face, but it might be around the 12 o'clock position.
I mean, you can use clock face. It's just an exam purpose. It may be tricky. You keep on things so that you can use it. It's for your own ease.
Yeah. And then around this density, I can see some clips. They look like surgical clips. So in my normal practice, I would compare it with the previous. Obviously, they've had surgery there, so I would compare it with the previous study. I can see in the 2016 study, the irregular radio opacity wasn't as prominent then. So this makes me concerned about, obviously, about a recurrence if there was a previous surgery there for, say, cancer. So what I would do is,
what type of surgery would that have been? What do you call it?
It might have been like a local excision.
Yeah, wide local excision. Good. Yeah.
A wide local excision. So I would this is a screening mammogram. So I would recall the patient and then essentially do an ultrasound of the region, and then I couldn't really see any axillary lymph nodes that were enlarged on the
Yeah, it's not very good
ML
mammogram.
wells.
Yeah.
Yeah. So I would do an ultrasound on the area of concern and then also the axillary region. And obviously, if there is something suspicious on the ultrasound there, because this is almost like an M4. I don't know if you'd apply the grading.
Yeah. You probably.
Post.
Yeah, you can still apply the gradings. Again, I said,
Yeah.
it's a difference between UK and USA. So in UK, if I would have seen it, I would still, to get the message through, I will still say it's M4. So the message here is, you're right. You need to look at the previous mammogram. So adjacent to the surgical clips at the site of previous wide local excision, there is increased opacity, which wasn't seen on previous mammogram. And there is skin thickening in the left breast, but this may well be related to post-therapeutic changes or post-radiotherapy changes. However, given this increased opacity, given patient's past medical history, I would be highly suspicious for recurrent disease. So I will proceed with ultrasound, do a biopsy, and then you can put a localization clip, or you may not, because obviously there are surgical clips. Sometimes it gets tricky, and then obviously auxiliary assessment, and then MDT discussion. Yeah. So
yes. Yeah.
So,
thank you.
Okay. Again, it's a tricky one, but see if you go.
Okay. So this is a standard. I can't see the CC view, but I assume it's a standard 2 view of mammographies, and it's of a patient who's symptomatic in the left breast. And it's quite a dense. There's dense fibroglandular tissue in both breasts, but I can see in the left breast that there's fine pleomorphic calcifications behind the posterior nipple line, practically reaching the pectoral region, and it's in a segmental configuration, and I can't see any nipple retraction or anything like that.
It's difficult to assess on this one. It may be, it may not.
Yeah. But given the appearances of the calcifications, it makes me concerned for maybe it could be an M4 or M5, given the characteristics. So I would probably do an ultrasound and assess the axillary region as well. So I can see there's a poorly defined heterogeneous lesion in the upper inner quadrant of the breast. There's some posterior shadowing, but this makes me concerned for a malignancy or an aggressive lesion. So I would do a biopsy of this lesion, and then I would assess the axillary region if there's any involvement there, and then put a marker clip as well on this lesion, and then check post marker clip insertion, get mammograms to see if it's corresponding with the one in the mammogram, because that one was behind the posterior nipple line. The segmental.
Yeah, so it is behind the nipple line, probably slightly little, but looks more diffuse,
Yeah.
So probably, and again, you have to remember this, when you're doing the mammogram, you pull the breasts in front, and when you're doing ultrasound, patient is lying on her back, the breasts fall back. So there is, a bit of change. But I agree, you'll do the biopsy, you do the clip, and you do the mammogram, and then if you see if it's corresponding. The other thing you can do, you don't have to in this case, but you can X-ray the specimen as well and see if you got some calcification on specimen X-ray. So that will, double confirm that you're in the right space. again, with the extent, someone was asking if it's a fairly dense breast, which it was. So here is an indication for the MRI as well, because
MRI,
you may have to see here what is going on here. Is it just a glandular tissue, or is it something else going on? It's quite
yeah,
asymmetrical, and these are the microcalcifications in this region. So
yeah,
fairly dense breast tissue. So here will be the indication for the MRI.
yeah.
Okay.
And
Mhm.
sorry, just based on the appearances on ultrasound, is it also? Yeah, I suppose the MRI definitely will come into play anyway.
Yeah, and it will, because fairly dense breast tissue, and you have
Yeah.
to see the extent and then assess. So yes.
Okay. Thank you.
Okay, the next case.
So I'm presented with the standard two views of CC and MLO in this patient that's symptomatic. And right off the bat, I can see that there is a fairly dense radial opacity in the along the posterior nipple line, quite close to the pectoral muscle. There's also some nipple retraction. Normally, I would zoom in to see if there's any microcalcifications. There's no definite.
It's a male patient, yeah. So it's a male patient, just let you.
Yeah. So, but this density that I can see, it's not flame shaped or anything. And while it's in the posterior nipple line, it's not really kind of like could be described as retroareolar. There's some density in the retroareolar area, but there's a lesion that's separate from that, which is the one closer to the pectoral. So essentially, with the nipple retraction and with the lesion in the kind of the lateral, not lateral, but posterior nipple line, I'd be concerned about a malignancy. It doesn't, because it doesn't have the confirmation of like a gynecomastia, which is usually flame shaped in the retroareolar region. So I would do an ultrasound of this lesion. So on ultrasound, I can see that essentially there's a relatively it's fair, I suppose, fairly. There are some areas that are fairly well defined. Oh, here it's not well defined. It's not well defined here. It's irregular, and there's some posterior acoustic shadowing. This makes me concerned for it to be a malignancy. So I would do a biopsy and essentially put a marker clip in, assess the axillary region. Although I think, and you showed it earlier, and the cortical thickness was not that significant. But I think because of how suspicious, I don't know if it's proved. I don't know if just how suspicious this is. I'd put a marker clip in, and then check on post mammo if it confirms the position, and then send off for biopsy for pathology, and then bring to the MDT for discussion. Essentially.
Yeah. Okay. So yeah, that's good. So we'll probably go to the next candidate. Good, thanks. Is there I don't think there was any calcification. Do you have to put?
No.
Do we have to put clip? Yes, we have to put clips. Sometimes you don't know, if it's going to be a malignant or benign. So it's best to put a clip. Again, post-biopsy memo of sample or breast. If you're talking about the last case, post-biopsy memo of the sample, so you can do both, or you can just do the mammogram of the breast just to see whether the clip is in satisfactory position. So, but in UK, again, if you have the services, you do both. Okay. So yeah, we can get to the next case if they are available.
Yes, sir. Assalamu alaikum. Good evening.
Good evening. Good evening. Give me a second, see if I can open the cases. Just Let's try to get the case. This is I may repeat a couple of cases, but then the other cases as well. Just bear with me.
So it's okay. Take your time.
Someone is asking previous cases their clips. I don't know if you are talking about the male patient or the one with the post surgery. If the post surgery, they were clips, no calcifications. So, should we expect calcification mass and male breast? Yes, you can have calcification in male as well. Diagnosis of male breast, it was male breast cancer. How often do we have to follow up in the biopsy negative lesions? Again, this is more in your local guidelines. So if you are satisfied that it's a negative and you have done all the resources, so probably 6 months to a year. Male breast case was a malignant clip. I don't have any biopsy clip images, but I can probably check. Okay. Just give me a second. Just need to. I'll probably start with a different case. Not the breast, but some other case, just to get you going, and then we'll see. Okay, so let me just share if I can. Okay, we'll start with this one. It's a chest X-ray, not the breast, but this is just to get you going. Yeah.
Okay. So I'm presented with chest X-ray frontal projection of a skeletally mature female patient. Here I can see that there is opacity seen in the left hemithorax, uh, just lateral to the arch of the aorta. This has well-defined margins laterally. However, the medial margins are seen to be merged with the mediastinum. I can see the aortic contour through this opacity, and I can also see the hilar and hilar vessels through this opacity. I'm looking at the ribs. I can see the ribs through it. There is no rib destruction and no splaying of the ribs. Um, so, concluding my findings, it's likely anterior mediastinal lesion as it is obscuring the cardiothoracic border. So I will like to see the previous chest X-rays if available, any previous imaging. Otherwise, I will like to proceed with the contrast enhanced CT scan of the chest for this further evaluation. However, the differentials could be any vascular lesion, could be any aneurysm, or it could be lymphoma, or but I could not see any calcifications. So less likely would be any teratoma.
Excuse me, your image is gone.
Yeah, and I'm just coming. I was
Yeah.
opening something. I was opening the other one. Sorry. So yeah, that's the MRI. Just I've given you a single short for the
Okay, on
same.
MRI T2 weighted images, I can see that it's a cystic lesion. It is
Mm-hmm.
hyper intense with well-defined margins.
Mm-hmm.
However, in my routine practice, I will like to scroll for any soft tissue nodule within it.
Mm-hmm. Mm-hmm.
Otherwise, on the spot image, it could be a thymic cyst as it's seen in the interior mediastinum and is a cystic lesion.
Mm-hmm.
Other less likely possibility could be a hydrated cyst or
Not headed, that's as I say, anterior mediastinal cyst. Okay,
uh,
simple.
yeah.
Okay, good. Okay, so just give me a second. Give me a second. I don't listen. Okay, so I'm just gonna share the screen with you. Sure, if it's for some reason it's not coming through. Give me a second. Sorry, just give me a second. I'm just trying to, get it right.
Yes, sir, no worries.
Yeah, go on.
Okay, I'm presented with mammogram of both right and left breast,
Mm-hmm.
craniocaudal views.
Mm-hmm.
I can see that the bilateral breast parenchyma is predominantly fatty with scattered fibroglandular tissue, making it type C breast.
Mm-hmm.
I can see that there is a radiodense opacity noted in the outer quadrant of the left breast.
Mm-hmm.
This density has it is ill-defined and has some architectural distortion, and
Mm-hmm.
there are clustered microcalcifications seen within it. In my routine practice, I will like to zoom it.
Mm-hmm.
Um, and will advise the zoomed view. Okay, on the zoomed image, I can see that there are adjacent mild speculations seen adjacent to this density. And there are scattered coarse, benign looking calcifications seen scattered in the bilateral breast parenchyma. There is no adjacent skin thickening seen and no nipple retraction. I cannot see any other focus of suspicious lesion in rest of the bilateral breast
Mm-hmm.
parenchyma. My routine practice, I will like to see the MLO view. Um, this of the breast, and also like to proceed with the ultrasound, and
Mm-hmm.
also like to examine the axilla.
Mm-hmm.
And other than that, on this on this one view, I will categorize it as M4C lesion.
Yep. So probably M5, I would say. So, I didn't have the MLO view for this one, but you're right. So there's an ill-defined speculative lesion in the outer aspect or lateral aspect of the left breast with associated microcalcifications and no skin thickening. His right nipple looks okay. Left probably slightly, retracted. And then there are scattered benign calcifications in both breasts. So you will proceed with the ultrasound. You will do ultrasound guided biopsy, auxiliary assessment, and then in the biopsy you'll insert the clip, and then you will check the post marker check mammogram of the left breast as well, and then refer the patient to surgical team. Okay.
Okay.
So yeah, the other one. Just let me just get. Okay. So let me just share this one with you. Okay, can you see? So
Yes.
yeah. So again, we only have MLO views, not for the CC views for this one.
Okay. I'm presented with mammograms of both breast, right and left, MLO views. The breast tissue is fatty with scattered fibroglandular breast parenchyma, again type C. I can see that there is an opacity, radiopaque opacity seen in the upper quadrant of the left breast. Um, it has ill-defined, indistinct margins. However, I would like to zoom to see for any microcalcifications which I am unable to see at the moment. However, there are some areas of architectural distortion noted adjacent to it. There is an other nodule seen adjacent to it, just superior to it. Could be a satellite lesion. Um, yeah, just above it. Yeah, this one.
Okay.
Okay. However, I cannot see any other lesion in rest of the breast parenchyma. There is no skin thickening and no nipple retraction. I will like to proceed with the ultrasound examination and also the auxiliary examination, and like to proceed with the biopsy as it's uh, again Barrett's 4C or lesion.
Okay, that's fine. And then obviously you do biopsy, you put a clip in, and then
Yes,
you refer the patient. Okay.
refer to the breast surgeon.
Yeah. Yes. Okay, just give me a second now. Now, so I think that's the all of it. I'll just go through things, quickly, just to, you know, recap what we have discussed. But let me just share the screen. Give me a second. Someone was asking about the. Yeah. Can you see the screen or no? Can you?
Not yet.
No, there won't be any cases, but still. Okay, let me just try again if I can. Still not? No, nothing coming up?
No.
Some issues. No, still nothing coming up. Nothing, is it?
Yes, nothing.
I don't know, for some reason it won't let me share for say. I don't know what's going on here. Let me see. Still no. Yeah.
Yeah.
I don't know. There's something wrong with so because I'm trying to share this PowerPoint again, but I can't for some reason. I don't know why. So
You have option stop share and then try again.
screen. No, I don't know. There's something else going on. I was able to, s- I was able to share it before for some
One
reason.
option is to
Hmm?
send me and I'll share from here if it is possible. Otherwise, leave
Yeah,
it.
I can try that. Give me a second. If I message you directly here, is it or I can?
You can WhatsApp me. You can.
Yeah, because I can see it on my screen for some reason. I don't know why it's not there. Let me try if I can do the other way. If it can just do it. No, I think for some reason it's not reading my that screen. I don't know what happened here. So I will just quickly go through the things we have discussed uh, for today in terms of what we need for the breast, especially in the FRCR exam. So the they will probably start with the mammogram first. So just the so you just describe the mammogram as standard 2-view mammography ML and CC views of the both breasts. Then you have to describe it in a way that uh, excuse me, I'm just see if I can, because I just want to write and show you from that way. So I think the computer is stuck. Probably. So again, sorry for this. I don't know why it's happening now. But all I would say is, when you're explaining, don't try to complicate things for yourself. Okay, just describe in a way standard 2-view mammography ML and CC views of both breasts, uh, fatty breast tissue or dense glandular breast tissue bilaterally. Then explain there is an ill-defined opacity in the right breast or left breast, and then mention the quadrants, associated skin thickening, nipple retraction, microcalcifications, and axillary lymph nodes. Then you will jump onto the next step and say, okay, based on the mammographic findings, I'll proceed with the ultrasound of the right breast and axilla for further assessment. Then you will explain it on the ultrasound and ill-defined opacity corresponding to the mammographic findings in the upper outer quadrant of the right breast. This is suspicious, and I will classify as M5 or M4 and U5 and U4 ultrasound. And I will proceed with the ultrasound guided biopsy of this lesion, and it will insert a localization clip. I will do a post-marker check mammogram. I'll do auxiliary ultrasound and make sure there are no abnormal auxiliary lymph nodes. After completing your assessment, you will refer this patient to either the surgical team if you're doing a symptomatic clinic, or multidisciplinary team meeting uh, to discuss the biopsy results and the clinical findings. So these are the basics. Just remember, MRI, there are certain indications for the MRI. Not all every patient needs an MRI. So if they are fairly very dense breast tissue, very dense heterogeneous, and the mammogram is limited, you will do MRI. If it's a lobular cancer, um, because lobular cancers are more tend to be multifocal, you do MRI. If there's a discrepancy between the clinical and a radiological findings, and then you do MRI as a problem solving, or you do it for the to assess the breast implants. And last but not least, you use it for the assess the response to chemotherapy. So neoadjuvant chemotherapy, patients who are not going for surgery initially, but they're having chemotherapy, you will use the MRI to assess the response to treatment. So this is how you go. And other than that, I don't think they're going to ask you much more in detail. So breast cases, if you've got a case which you have to write, you should be able to finish it in 5 minutes. So just practice on your report, and the report shouldn't be more than a line or 2 lines. I know you need to dictate nowadays, but still you can just get rid of extra words. Don't write there is a mass, just write ill-defined mass in the upper outer quadrant, ill-defined opacity in the upper outer quadrant with microcalcifications. So get rid of all the extra words and try to type, quick with the just relevant buzzwords. So in buzzwords in the breast will be ill-defined mass, microcalcifications, architectural distortion, density, these kind of words. And that's it. And obviously nowadays everyone puts a clip in. Just remember, there might be some different guidelines, in locally where you work. So there's no harm in us saying that we will do a targeted ultrasound of the right breast, or we'll target ultrasound of the lesion, or we will do the whole breast. There's no harm. People asking about CT and stuff. Again, CT, in UK, mostly CT get recommended after MDT discussion. So you don't, suggest CT right from the outward. You don't. You patient gets discussed MDT and then. But again, these practices vary all over the world. Some places do MCT straight away, some don't. So again, someone is asking that axilla should be assessed by the ultrasound anytime we do an ultrasound breast, right? Well, it depends. You do ultrasound, especially if you're doing a first assessment ultrasound, you will do axillary ultrasound, and that's the first one. And then afterwards, again, depend on clinical needs. But if it's a first assessment, yet you have done first mammogram and patients coming for first ultrasound, you will do the ultrasound of the breast anyways. So yeah, any more questions, let me know. I'm sorry, I don't know why I couldn't share the biopsy. In UK we do biopsy. Okay, FNA, as I said previously, only you do FNA for the difficult lymph nodes which are very close to the vessels. Only then, to avoid any injury to the vessel, you just do otherwise you do biopsy. 14 gauge normally we use in UK. So yeah, anything else you want to ask? So I just want to know if I am in working in Saudi, so if you want to check if you want some more sessions, or you want to reach directly, then I'm happy to guide you through. What is this post mammo check? The post mammo check mammograms is the once you do a biopsy, you insert a localization clip, so you confirm the position of the clip that you have biopsied the right area which we're looking at. You do it. So it's after that. Okay. Anyone else? You're welcome. I hope it was useful. And the cases I've showed you, you're just going to get those kind of cases, in the exam. You're not going to get the. My email was there. I will just write it here for you as well. So I'm still using my NHS email. So yeah, just let me know. Probably because I work in King Faisal, so I mean, to be honest, I think the pathology I've seen in Saudi is quite a lot more extensive than what I've seen in UK, and the breast cancer is very very common in Saudi, especially in the young patients. So you see, 21-year-old, 23-year-old with metastatic cancer. So it is quite alarming here. So yeah, so I hope it is useful. But obviously, if any confusion, anything, just drop me an email. I've written my email, and I'm happy to guide you. I hope I haven't made it difficult, but please do let me know. Okay, thank you, and thank you, Dr. Khan, for the opportunity, and hopefully I'll see you soon somewhere. We'll catch up with you.
Thank you very much. It was
No,
it
no,
was extremely useful, and I'm sure everybody gained a lot. We hope to welcome you once again
thank you.
later in the year or somewhere whenever you have got
Definitely.
time.
I remember I did my first teaching not with you, but there was a Leicester course. I started teaching since 2017, and
Right.
uh, and then I did some teaching with you. Probably 2021 and COVID time as well. When me myself, Dr. Altaf, and Dr. Asia, I think we're together when we did the breast session. So it was quite enjoyable. But
Yeah, that was our
mm,
ST1 2-year teaching program, which
yeah,
was, I think, this was 2022 December. You did that
yeah,
session. I remember it,
yeah.
where
Mm.
we concluded our 2-year teaching program. So
Yes,
yes,
yes, yes. It was good.
yes. So that was very
Yeah,
nice.
yeah. Thank you.
So thank you very much,
No,
and
thank you, everyone.